First of all, I want to thank the organization for the ALS Nordic conference for inviting me to come here and speak about rehabilitation. I'm not coming, no, and especially a big thank you to you, Mette. You have made a tremendous job here. Thank you very much. I'm not coming with a specific subject.
It doesn't hear well.
Hello? Is it better now? Perhaps I should switch it on then. Is it better now?
Yes.
Okay. I'm not coming with a specific subject today. I'm not speaking about ventilation or about tubes or something like that. I'm speaking much broader about rehabilitation. And I asked Jens what I'm going to speak about, and he said you should speak about the Danish Rehabilitation Center, and I'll do that. But then it's not about ALS, then it's about rehabilitation for people with neuromuscular disorders. And I think it's right to do it in that way, because I don't think that rehabilitation is something specific for diagnosis. Rehabilitation is something specialized for a person with a diagnosis. I think that is very, very, it's had a big meaning to talk about the persons behind the diagnosis and not talk about the diagnosis all the time when you are talking about rehabilitation. This is a picture of the grown-up person, man with Duchenne muscle dystrophy, and it's a whole group in Denmark. You can't see all of them, but they are there. There was about 64 in this weekend to the meeting. And the specific with that picture is that they are not living, if you are looking at it in the literature. It's a new group of people who are living because you have rehabilitation. Because you in the last 10 years are giving ventilators. You are taking serious that Duchenne boys can be men. And that's specific. That's not the group, that's the person who is sitting there. And I think it's something the same we are talking of when we are talking about ALS. If you are looking back in the history, there was no person living with ALS. There was a lot of ALS diagnosed who are living in their beds or were living in their homes, but they were not really living. And I think that's the problem we discuss. And you can put questions, I can see you. So if you want to put questions to me, or you want to see that I'm not, I want to argue what you are talking about now, then do it. So we can have the discussion here and now. And I will also leave a little time afterwards so we can discuss it at that time. In Denmark, we have the Rehabilitation Center for Neuromuscular Disorders. It's everybody is telling that it is very easy in Denmark because Denmark is such a little country. Especially when I'm talking to people in Norway, they always say, "Oh, that's just because you have such a little country. You can go around it. You can't do it in our country." So that's why. But that's not the why. The why is absolutely that we had a patient organization. We had a patient organization in the 70s. It was Muskelsvindfonden. And they was, at that time, they was telling that when you have the diagnosis of all kinds of neuromuscular disorders, especially spinal muscle atrophy type 2 or Duchenne's muscle dystrophy, they was telling you can't do anything with this. You have now you have the diagnosis, then you can go home and have a good life. And of course they could go home, but they couldn't have a good life. because it was impossible to have a good life because nobody was knowing how to do with this when they was coming home. And a few of the patients, or especially one of them, Evald Falk, he started the muscle dystrophy organization, Muskelsvindfonden, at that time, and he had some persons around him, some professionals, who said, of course we can do something. We can't give medicine, we can't give a lot of things about that, but we can care about it. And just the things about care, about to have it, and tell people, and how to care about it, and disseminate knowledge from other patients, how they was doing things, so they could do it together. That was the things which was behind that. And it was in 1970 they started that, and already in 1976 they started the rehabilitation center. So the only thing that was telling in that was that they couldn't use what the professional was telling them, because the professional didn't know anything about how it was to live with the condition in their homes. So they had to disseminate the knowledge from the patient themselves. And that's what they were doing. And then there was making a counseling where they took persons who went around to the different persons and asked them, how is it to live with Duchenne? How is it to live with spinal muscle atrophy? And then the patient was telling them how it was. And then they could disseminate this, and then they could go out and tell other people about it, especially about how to care when you have pneumonia. Because you can do a lot if you know how to do it. How to cough, how to help with coughing, and so on. So that was the start of it. So I think it's so important that you know that rehabilitation is something about living at home. It's something about taking care of. It's something about to look at the life, especially you have at home, not the life that everybody has, but the life that the specific person has. At that time, there was a very few diagnosed. When I came into the rehabilitation center in 1988, we was talking about 17 different diagnoses in neuromuscular diseases and in the rehabilitation. If you look today, we are talking about 136 different diagnoses. It's very rare disorders. And ALS is one of them. But what you know is that ALS is not one diagnosis. ALS is, there's many different forms of ALS. We don't know anything about that today because it's not a gene disease, not a single gene disease. So there is very many. So the people are very different. If I should tell it, I can say that the people with the persons with ALS who are here are very specific group of the persons with ALS, because when I look around with the more than 400 people with ALS in Denmark, I can see they are in groups, and a lot of those who have ALS will never be able to come to a congress as this one. So it is persons who are special who are here, but they can give a lot back to the others who can't come here. Yes, we are situated in 3 positions in Copenhagen and in Aarhus and in Korsør. And I will talk a little about the place we have in Korsør later, because I think one of the things we are doing in the rehabilitation is that we are doing different form of courses where we invite people with different diagnoses or with a specific diagnosis to come here and have courses, because the courses is not only where the professionals are telling the person with ALS or another diagnosis about the conditions, but they are telling themselves, and in between, so they're giving each other a lot of courage when they are coming to these courses. I think the courses, in a way, is like to have conference and so on. It's not so that you are telling a very many new things when you are coming to conferences, coming to other things, but you are talking together with a lot of people who can give you courage. Yeah. Here I have taken the largest diagnosed group in the rehabilitation center in Denmark. And I only have done that because I took it yesterday, because I heard yesterday that Julius was telling that in Norway there was about 50 new ALS every year, and that there was about 200. I think it was something like that. It was the same in Denmark. If you go 5, 6, 8 years back, they was telling us that there was only about 60 with ALS, 60 new persons with ALS, and there was about 240. But that's not the right number. There are many more. I'm sure that it's only because they are not diagnosed. Because a lot of persons with ALS have the form which is very aggressive, and they are only living very short with that. And it's still so that the doctors in I know in Denmark, but I know in Norway too, they are a little afraid of putting up the diagnosis ALS. But if you are talking about rehabilitation, then it's necessary to know the diagnosis, because you can't go into a specific rehabilitation before you know what you have of the diagnosis. So I think it's so important that we are coming up to that it's not dangerous to have a diagnosis, it's necessary to have a diagnosis. And I'm sure that if there should be one in a lifetime who you have to go and tell that, of course you was wrong, you haven't ALS, she or her will not be very, very angry with you, I'm sure. Rehabilitation is medicine. You can read in books about rehabilitation, but I think what all mean about rehabilitation is that it's necessary that you have continuous and coordinated measures to enable people to remain in or return their usual environment and their chosen social and professional life. I think it's so important that you make a plan when you have this, and that you all the time can be continuing what you are doing. Because very often you see that you are coming into a hospital and then you are coming home, and then they're going a time, and then there happen some things, and then you go back to the hospital or something like that. If you have these interruptions in the rehabilitation, then it has no meaning. It's necessary that you have it to continue all the time, and that before it's necessary you have decided what is going to happen next. If you're not doing that, then you can't have a rehabilitation process. This is a picture of Per. He have not ALS. He have Duchenne's muscular dystrophy, but have not. That's the same in this. It's just something about what happens with Per in the system, because he is in a system where he you could also take all the other things out and write in the top of him, a man in his best age. And he's not ill. He had a ventilator, he had a wheelchair, he had a helper scheme, He had 2 sticks in the back to keep him up, sitting up, but he can do everything. But to manage this, it's necessary to go to a lot of different places. You have to go to the hospital to something. You have to go to the ventilator center. You have to go to the neurologist. You have to go to the orthopedics. And in the social system, there's something about housing. There's something about helpers. There's something about living conditions. And when he's going to work, you have something to do with to help in the workplace and so on. And I was talking with Pierre, and he said in 4 years period, he had more than 100 direct persons who had some decision about his life. And there was more than 400 secondary persons in it. So if you have so many people because he had a normal life, he's living alone, he had a family, he had a work, but to keep that up, it's necessary to have so many people in it. And that's why, I mean, it's so important that we always have a line how we have to manage this. And that's what I mean is rehabilitation. Rehabilitation is a process. It's a process we always are continuing. It's a process between different governments. It's a process between hospitals and daily life. And we have tried in our rehabilitation center to say that how can we manage that for people in Denmark with neuromuscular disorders? We say that in the hospital there are physicians. There's not only neurologists, there are a lot of other physicians who have to work together. There's like psychologists, there are physiotherapists, occupational therapists, social workers, speech therapists, nurses and so on. And the persons are not going to live there. They are not just diagnosed there and then they're coming there when they shall have a respirator, when they shall have a tube or something like that. But it's only a few days they are there. The rest of their time they are going to live at home. And it's necessary that you are a specialist on the diagnosis because it's always a rare disorder, so you haven't learned anything about it. So how can you get the expertise from the specialized hospital out to the local position where you are living? Because you have all the persons locally. You have the physician, you have the GP, you have home cares, you have district nurses, you have social workers, a physiotherapist, a occupational therapist, teachers, educationists, and the employer. They are all local, but they don't know anything about the rare disorders. That's why we are saying we make a rehabilitation center who can go to the hospitals, be there together with the specialists in the hospital, and afterwards go to the local and supervise all the staff in the local in the local positions. Because most of them can do the rehabilitation if they are not afraid of the rare disorder. Because what is going to be done with the medical rehabilitation, that will be done in the hospital, in the specialist side. What is going to be done at home is only to make a life for the persons, but it's necessary for you that you know what you are doing is the right thing, because persons who are professionals can't do their things if they are afraid of doing it. So it's so important that they have someone who can supervise them. And of course the person himself can do it, but he can't manage everything. So it's so important that he have or she have help to have it done at home. I can say that one of the most important things is about home cares. Because if you have ALS persons, not the stable type that you have here, but much when you have the type where there is a big progression, it's for people very, very different to work with people where there always are progression, because you think you are not doing the right things. It's necessary to know that what you are doing is a rehabilitation, because rehabilitation can also be when you slow the position, when you're doing it better. So it's so important that also the home cares, but also I know it. I was GP before, and I know the GP is very often are saying, "Oh no, we can't go into this. This is specialist job." There's nothing to do with specialist job, because it's just to do what we have to do, because we know what to do, because the specialist can tell us it about it, and the person can tell us themselves. So I think that's what we can do best in the rehabilitation center. That is to be supervisor for the professionals at home, and of course also for the family. I'll come back to that. Yes, our hospital is brickless, and so we come everywhere. And I think that is important to stress out, because when you have a diagnosis ALS or Duchenne, it's very important that you can stay in your home. We can see in Denmark that we have very, 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 very few persons who are not in home. I know it's the same in Norway, and I think it's the same in the Nordic country. If you're going to other lands, to other countries, then they are often in nursing home and so on. So it's necessary that we can come out, and I'm sure what we see is that when you have a person with ALS, we are coming nowadays when they have the diagnosis. We are coming there 2 weeks or 3 weeks after they have the diagnosis. We are coming home, and many times at that time we are just talking with the person themselves, their families, and we are telling about because if it's only some weakness in a hand or some in a foot or something like that, then we are telling them and giving them all the all what will happen in this. But very often they don't want to know it at that time, and I think that's all right if they don't want to know it. But it's necessary that the person knows that we want to tell them if they want it, and they can, and they have the material or the books or something like that about what can happen in this. And then we say that we will come at least within the next 3 months, or if it is necessary to come before that. And then we continue to do that in that way. But that means that we will only, with the most families, it is only necessary that we will come there more than, in average, 2 times a year. And that means that if we have a staff in Denmark for neuromuscular disorder, we have a staff of 30 persons in the whole country, then we can come around. So it's not more than that. It's very, very cheap. It's a little center who have thousands of 1,000 persons who are in the center, and we can do that job for 30 persons. And when you tell me in Norway that it's impossible here, I'm sure that you can do it in the same, because often it takes 1 day to be out for us when we are out. And the most places in Norway you can reach in 1 day, and you can also come back. So it's not anything. It's not something about how the country is built. I think it's about. I think it's more about that we in Denmark have the Muskelsvindfonden, and in Norway we have the Foreningen for Muskelsyge, who have not been so strong as the Danish organization. And a lot of rehabilitation is politics, and you know that from the daily life. It's not. A lot of rehabilitation is not medical treatment and so on, because that's one part of it. The other part, that's the political system, how you are working in that. And it has a big difference in different countries. Yes, something about that. I said, if you look at a person, so you have the illness of the disease and the organ, that's the medical treatment. If you're talking about the difficulties and pain the patient has experienced, then you try to think about the psychological treatment. But if you look at rehabilitation, rehabilitation is about the healthy person. It's not about. It's about the part which is functioning and which you can do more for, and that's why I say that rehabilitation is very often the same things for different diagnoses. You just have to know which part is the healthy part, the part that you can put up about. Yes, this is. I'll just take that the normal system which we are living in the Nordic country is that we have a dysfunctional perspective. Very often we always say that we have a reactive intervention. We intervene when the damage is done. It's normal here that we are going to the doctor when something happens. At that time, then you can have a prevention, and then you have the mechanical reduction problems and task delimiting. What is enough is terms of relief. That's also the way we are doing it, and the time system. It was this, I would say, that was, I think, when you have to do with rehabilitation, then it's necessary that you are functional, and that's what we often call it functional rehabilitation. It's necessary to have active intervention. You have to strengthen the person's and family's resources and potentials. So, and you know that. You know that if you have a family with ALS, it's so important that you are looking for that. You're not looking for just to treat, but you are looking for strengthening the person's and family's resources and potentials, because they must have a lot of resources to manage, and I think that's very important. And you're looking about the lifetime perspective. I was telling you before that we was coming out to the counseling report. That means when we are coming in the homes, then we always make a report, a rehabilitation report, and also a report which is going out to the next time we are coming, so that you all always know what is going to happen in the future. We are also doing the description of a physical status, so that we know exactly what it is for a person who is here in the physical meaning. But just because it's easier to work with the mental part then. And it's so important that we have the family's wishes and the conclusion are listening. So they always is in the center. And I know that everybody is talking about that, but it's also necessary that you are doing it, because they are individuals. That's why I mean that that person with ALS is not alike. They are very dislike, and that's their family are very dislike. So it's important that you have that note. And then and I think it's important that we know who are responsible for the time going and what is going to happen in the rehabilitation field, and what is the time horizon. Yeah. One of the things we are doing in the rehabilitation center, I was talking a little about it before, was that we have the family courses, and I think that's again one of the things which is very important, is that ALS is not illness for the person himself. It's illness for the whole family, if you say it that way. They are all in it, and then we invite to what we call family courses, and there we are talking about a lot of different things. When it comes to ALS, I think it has been we have developed another form of course where we are taking the persons who have the persons and the family who have the same problems, because it has been so difficult to be professionals when you come out and look at the family and see here it's necessary to talk about respirator, for instance. And if you're talking about that and you are coming and you're just sitting with the family, it can be very, very difficult, because you can't tell them about the professional things in it, because it's not only to have the air, it's not only to live, it's something about what do you have of resources in the family. How are we going to talk about respirator? Sometimes when I am in a group like this one, it is just like when you have ALS, that all people with ALS should have a ventilator, should be in tracheostomy and so on, because then they will live, and that's her meaning. But if you look in areas where it's not very difficult to have respirators, and where everybody is introduced for the respirator, then it's only about 10% who will have it. And why we really don't know. And I think it's such a difficult question. But then we can take the families together, and when they are mirroring each other about this, then they talk about these very, very difficult issues. And they have a better talk about it and have a better way of decision. Yes, family courses is for... at least here. Yes.
Jeg spørger efter, om ikke vi kan bruge 5 minutter nødt til at fortælle om konsulentordningen, at vi arbejder med det.
Jo, det kan jeg godt. Yeah, it was a little about what I was talking about. I did it very quickly. We have the rehabilitation centers have people who are specialized in ALS rehabilitation. So we have ALS consultants, and they are going up to the family and make the reports and have meetings in the local society with the local physiotherapist, the local social counselor, and so on. And then, so we are sitting there together, and that's perhaps the most important things for the rehabilitation center in the ALS field. And they are. It's also them who are making the family courses and so on. But this report is following everybody who have ALS to the hospitals and to the local society. Jeg ved ikke, om det var det. We were talking about the ventilator, and I think I will just put a word on that because I think that it is a question which will come up in now and in the future, and it has been there for some years in Denmark, because it was first after 1990 that it was normal that people with neuromuscular disorders could have a ventilator. If I go back to 1994, I was asking different people about if they think that the life with a ventilator was a life. And this is not a person with ALS, but it's in principles it's the same. And if I asked the professionals, the doctor at that time, they were saying there was 80% of the doctors who was telling that to live with a tracheostomy, that was not a life worth living. And if we ask the average population about the same things, 50% of them said no, it's not a life worth living. But if we ask the patient themselves, it was opposite. 80% were saying that they think it was a life worth living. And I don't think that this have changed very much if you are going out to in the hospitals. It's still so that the professionals are the persons who mean that it's not a life worth living. And it's the patient themselves who have decided it, who say that it is a life worth living. And it's not only me who have asked about that, others have done the same, a lot of others have done it, and the end of that is that the only people you can ask about this is the person themselves. But that means that you have a big job to do, because it's necessary for you to tell about how it is to live with a respirator. But you can, as a professional, you can only do it in the professional way. And I think it's so important that you take the patient into this, so that people are meeting persons who have respirators, are going to talk to them. And I think that I can say that's what I think is rehabilitation. That's when the person or patients themselves are the decision makers, and can only take the decisions if they have all the, if they know everything about it. And the only people who can tell them about it, that is the persons who have the restoration themselves. And so it is in a lot of things in rehabilitation, that it is the persons who have tried it themselves who are the best to give information.